Good morning, everybody. Thank you for being here, and it's nice to see a lot of familiar faces. So I'm going to talk about diagnosis and staging. It's pretty broad because I wanted to make it across the different types of cutaneous lymphoma, but I'll, at the end, kind of talk a little bit more specifically about mycosis fungoides since it's the most common one. So, you know, a lot of times when people walk into my office and they have the diagnosis, the first question is, what's cutaneous lymphoma? Well, cutis means skin in Latin, and lymphoma is a cancer that begins in the cells of the immune system, or the white blood cells. And there are two types of lymphoma. There's Hodgkin's lymphoma and non-Hodgkin's lymphoma. And cutaneous lymphoma fits under the non-Hodgkin's category. So cancer of white blood cells affecting the skin is basically what cutaneous lymphoma means. The people that that are my patients, I know have had a little bit of this talk drawn out when you come in and see me. But on the right side is the whole immune system. And the two important things that I want to point out are the bone marrow and the lymph nodes. So those are going to be, we're going to talk about them a little bit more specifically. And the bone marrow is important because that is where you make your cells that are in your blood. And so there are three types of cells that are in your blood that are big categories. So the red blood cells, they take oxygen around. The platelets keep you from bleeding. And then the white blood cells are what are your immune system. So they help prevent infection. And if you look at the white blood cells a little bit more closely, we're going to be talking about the B cells and the T cells. So those are types of white blood cells that are important to fight infection, and they each have a different role. And those make up the majority of the types of cutaneous lymphomas. So what are the types of cutaneous lymphomas? Well, there are two big categories, the T cell lymphomas and the B cell lymphomas. T cell lymphomas are the most common. They're about 75% to 80% of the lymphomas. And within that category, the most common T cell lymphoma is mycosis fungoides. So the majority of patients with cutaneous lymphoma will have mycosis fungoides. The other big category of cutaneous lymphomas are the B cell lymphomas, and those make up about 20 to 25%. And within the B cell lymphomas, there are two main subtypes. Cutaneous marginal zone lymphoma and cutaneous follicular lymphoma. And then there's, I have another category which is about 1%. So this is actually the whole list of cutaneous lymphomas. So a lot of them are rare variants, but you can see up here is mycosis fungoides, and down here are the B cell lymphomas. So diagnosis. So cutaneous lymphomas are about 5% of all lymphomas. So if you think about lymphoma being a subtype of cancer, and then you think about the cutaneous ones, you can see that they're a really small subset of it. And approximately about 1,500 new cases are diagnosed in North America every year of cutaneous lymphomas. And as she alluded to, it can take months to years to diagnose these. And why is that? Well, it's because they mimic a lot of other conditions, especially really early in the disease. They can look like a lot of things. And so for cutaneous lymphomas, people a lot of times get diagnosed as having psoriasis or eczema, or sometimes even allergic skin reactions. For cutaneous B cell lymphomas, early on they can be misdiagnosed as bug bites or benign growths. And really the start of the diagnosis is a clinical exam by a dermatologist. So I added some pictures from the American Academy of Dermatology so you can see different types of early disease. And then I'm going to compare the early disease to other things that mimic it. So up on the right side is mycosis fungoides, and it's early stage, so it's these scaly patches. And down on the left, it's early stage mycosis fungoides that actually has a little bit of pigment change. So you can see how subtle that is. And these are diseases that are not mycosis fungoides, but that are mimicking it. So up there on the top is somebody who is allergic to nickel on their necklace, on the back. The person in the bottom is somebody who has eczema or dry skin. And then over here on this side is somebody that has psoriasis. So you can see how all these diseases look very, very similar early on. This is early cutaneous B-cell lymphoma. So these nodules on the skin. And I have two examples. The person on the top has a keloid, so it's a scar from an earring. And then the person down there has bug bites. So you can see how these can look very similar early on. So how do you diagnose cutaneous lymphomas? Well, the main way you diagnose them is with a skin biopsy. There are two types of skin biopsy. There's a shave biopsy and a punch biopsy. And what happens when you do a biopsy is you take a sample of the skin and you process it into slides. And what I mean by that is you actually put it in a little bit of formalin, which fixes it and makes it easier to cut. Then you put it in paraffin, and then you stain it with something we call hematoxylin and eosin, and I'll show you pictures of this. After that, the slides themselves are reviewed under the microscope by a dermatopathologist. So a dermatopathologist is somebody who's a physician that is trained to look at things under the microscope, and then specifically is further trained to look at skin under the microscope. So that is one of the things that I do. I'm also a dermatopathologist in addition to seeing patients. You can use special stains to look for specific types of cells. So you can turn them colors, usually brown, and that helps tell what kind of cells are there. So these are some sketches of what it is like to have a biopsy, which I know most of you know about. Up here is the shave biopsy. So obviously first the skin gets numb with lidocaine, which is similar to what they use at the dentist. And then you take a little piece of skin, and when you do a shave biopsy, you usually go down into the middle layer of the skin. And shave biopsies are really good to get a lot of that top layer of the skin, and the reason that's important is because that's a very good way to diagnose Mycosis Fungoides or other T-cell lymphomas, and I'll show you pictures. With a punch biopsy, what you do is you take a little cookie cutter-like instrument, and you also numb the skin, and then you take a plug of skin, which is about a pencil eraser size, and this is a little bit better technique for things that are B-cell lymphomas or when you want to get deeper down into the fat. So here are some examples of biopsies. So this is what a shave biopsy looks like on a slide after it's been processed. And this is what a punch biopsy looks like once it's been processed. Here you can see this top part is actually the epidermis, so the top layer of the skin that you feel. And then down here is the middle layer of the skin or the dermis. This is a picture of normal skin. So I just have the top two layers of the skin. So this is the epidermis, so it's what you feel. This stuff up here is called the stratum corneum, and it's what flakes off every day. And this is the dermis, which is in the middle, and here are the blood vessels. And you can see these little, I guess, blue to purple dots. Those are the lymphocytes, so those are the white blood cells. And you can see how many there are in normal skin. Not very many, right? Okay, so this is an image of Mycosis Fungoides. So what's happening here is you can see all these lymphocytes have come to the skin, and not only are they in the dermis, the middle layer of the skin, but they're actually going up into the epidermis, and that's what causes that itchy, flaky skin when they go up into the epidermis. So down here is one of those special markers that I was talking about, where you turn certain cells a different color. So here we're turning the T cells specifically brown. So you can see all these cells that are there are the lymphoma cells that are attacking the top layer of the skin. And you can see here how they're lining up along that top layer of the skin, and that's what causes the rash that you see. This is an example of cutaneous B-cell lymphoma. So again, this is a punch biopsy this time, and you can see all the inflammation that's here that's making collections. And this time we stained it with CD20, which is specific for B cells. So here you can see all the B cells that are there. So those are the two main types of lymphoma, the T cell lymphomas and the B cell lymphomas. So now moving on from diagnosis to staging. So why is cutaneous lymphoma staged? Well, staging tells you prognosis. What is prognosis? Well, prognosis is the best estimate of how cancer will affect a particular person. And this is all based on survival statistics, with the key word being statistics, and I'll talk a little bit more about that. So survival is the number of people with lymphoma who are alive at some point in time after the diagnosis. The most common statistic that we look at is 5 years, but for things like cutaneous lymphomas that tend to be more indolent, there's a lot of times statistics for 10, 20, and 30 years, and we'll talk a little bit more about this. So how is cutaneous lymphoma staged? Well, what we need to do when you have cutaneous lymphoma is know how much lymphoma there actually is, and is it anywhere else. So tests are done to determine the extent and stage of the disease. We start with a physical exam, so we want to look at all of your skin and see how much of it is involved. And then not only do we want to know how much of it is involved, we also want to know how thick the areas are, because that gives you an idea of the amount of involvement of the skin. We also do a lymph node exam, so our hands are pretty good in terms of picking up large lymph nodes, but they're not 100%, and that's why we do other tests. Blood tests are done that tell us if your liver and other things are working correctly, and that can tell us if there's involvement of other organs. We also look at lymph node and other organs a little bit more specifically with things called computed tomography scans or positive emission tomography scans, so PET-CT scans. And those are just a better way to actually go in there and look at those organs and lymph nodes that are, you can pick up smaller things that are there than with your hands. And then depending on the disease you have, whether it's a T-cell lymphoma or a B-cell lymphoma, we take a further look at your blood or bone marrow. And the further look at the blood is done by something called flow cytometry, which is a specialized blood test where you actually look at all the blood cells that are in there and see if any of them are cancer cells. And that's usually done for people with T-cell lymphomas. And then people with B-cell lymphomas, a lot of times will get a bone marrow biopsy. So it's like a skin biopsy, but you actually go into the bone and get the part of it inside to see if there's any involvement there. A little bit more of staging. So when we stage people, we talk about T, N, M, and B. So T describes how much of the skin is affected by the tumor. And we do that as dermatologists by percent. So one palm, patient palm, is 1%. And as I said before, we also look not only at the percent involved, but how thick it is. So we talk about things that are patches, which are you can barely feel, plaques, which are a little bit more raised, and then tumors, which are much bigger. N describes the extent of lymphoma in the nodes, and that's done both by palpating and those CT and PET-CT scans that I discussed. And sometimes if you do see something on these tests, then you will actually take a lymph node out and look at it under the microscope as well to see if it's involved. N is the spread of the lymphoma to other organs, so is it in your liver, spleen, other things like that. And again, that's originally picked up with that CT scan or PET-CT scan, and then sometimes biopsies of those areas need to be done. And then B is for lymphoma cells in the blood. And that is done, as I said, with that specialized blood test called flow cytometry. So a little bit more about staging. Once the values for T, N, M, and B are known, then you combine them and you get an overall stage of lymphoma. So this process is called stage grouping. And the way we stage things is from 1 to 4. And we use Roman numerals, so 1, 2, 3, and 4, with 1 being the lowest stage and 4 being the highest stage. The lower the stage, the better the prognosis or survival. And that's based on those statistics that we discussed. These stages are also sometimes subdivided into A and B, with A being better than B. So I think a lot of times it's very confusing when you get a diagnosis of lymphoma or cancer in general, knowing what to do with the staging, right? So I'm going to take a minute to talk about survival statistics. So what are survival statistics? They're very general estimates, and so they are true estimates. And they actually can vary a lot by stage. So somebody with stage 4 disease can have very different survival statistics than somebody with stage 1 disease, which is why I always tell people when they get diagnosed to make sure that if you're going on the internet and you're looking something up, you are looking it up according to your stage, because if not, you will not get correct information in terms of survival statistics. These are statistics, so they're based on large numbers of people, and they can't predict exactly what will happen to a particular person. So you're taking these big groups of people, you're following them out for years, and then you're coming up with a number. So it's an estimate of a group of people. It's not an exact science of a person, and I'll show you in a minute. The other thing that's interesting about these statistics is, the information is usually quite old, because if you think about these patients, they have to be diagnosed, and then they have to be followed. So when you have, 30-year statistics, you're talking about people that were diagnosed 30 years ago when there were different treatments, or perhaps things were not being diagnosed as early. So a lot of times they don't reflect advances in medicine, such as earlier detection, treatments, or actually the correct diagnosis, because that list of lymphomas that I showed you at the beginning, that's actually brand new, well, not brand new, but it's newer since 2005. Before, a lot of these T-cell lymphomas were lumped together and the B-cell lymphomas were lumped together. So the subsets under there were a little bit harder to pull out, so the statistics were not as good. The other thing that survival statistics don't account for are other illnesses. So is the patient older? Do they also have diabetes, high blood pressure, things like that? Did they respond to treatment? So is a person, they're just looking at how long a person lives. They're not looking at who responds to treatment versus not. And sometimes it's actually quite hard to pull out who is dying from the cancer versus who's dying from other things. So now I'm going to switch gears, and before I go on, I'm going to talk a little bit more about Mycosis Fungoides, just because I know it's the most common disease, and many of you probably have this. Are there any questions before I move on? Okay. So Mycosis Fungoides, that is also a term that people come in and they're like, okay, so do I have Mycosis Fungoides or do I have lymphoma? So it was actually first described in 1806 by a French dermatologist, and the name is actually quite misleading. If you translate it, it means mushroom-like fungal disease, and it was named like that because this French dermatologist described some skin tumors of a severe case having a mushroom-like appearance. And so this is kind of the first patient that we have a picture of. It's actually a portrait of a patient with Mycosis Fungoides, and it was Dr. Albert's patient, and his name was Lucas. And this portrait is when it was further on in his disease, but if you read the description by this French dermatologist, it actually describes that the disease started as a scaly eruption. So the last couple slides that I have are regarding the statistics and survival for Mycosis Fungoides specifically. And I'm going to show you two graphs. And they're not meant to kind of be looked at in detail. They're meant to give you an idea of when your doctor gives you statistics, what they're looking at and what they're giving you. So up here in light blue is stage 1A disease. And then down here in red is stage 4B disease. And here you're looking at the probability of survival, and here the number of years. So you can see that people with stage 4 have worse survival than people with stage 1. But those lines going up and down tell you that there's all kinds of points in there that you're following, so not everybody is falling at the same place. So this is based on 1,502 patients, and the data was collected between 1980 and 2009. So that's pretty old. Remember I told you that the new classification came up in 2005. This data is also from St. John's Institute of Dermatology in the United Kingdom. So sometimes in Europe, diseases are treated differently and we practice differently. So this is one set of statistics that I was going to share with you. And here's the second set of statistics. So this is 525 patients, and they're from Stanford University, California. And this data was collected between 1958 and 1999. So if you look at this data, the data actually looks a little bit better for survival than this data. Why is that? Again, it's just how you collected, what you exclude, what you don't exclude, and you're looking at, lots of years, so lots of things can happen. We're getting better at diagnosing these diseases. We are catching them earlier. And the other thing that's happening is that I think now we are able to really capture true, for example, Mycosis Fungoides versus other lymphomas. So the data over time should get a little bit cleaner. The other thing I was going to point out is both of these sets of data come from multidisciplinary lymphoma clinics. So these are clinics where you have dermatologists, oncologists working together. So if you look at other data where patients maybe don't have access to those things, the curves also may look very differently. All right, so in conclusion, cutaneous lymphomas are rare. Most of them actually follow an indolent course when confined to the skin. So when we're talking about staging, those stage 1A patients only have disease in their skin. They don't have it in their lymph nodes, blood, or other organs. So as you saw with the survival statistics, people do well. The diagnosis may be delayed. And why is that? Because I showed you pictures that gave you examples of how early disease can mimic a lot of other benign things. Once you make the, suspect the diagnosis, to make the diagnosis, you've got to do skin biopsies. And the images I showed you of those skin biopsies were images of people with well-established disease that were easy to see under the microscope. I don't always get that. A lot of times with very early disease, the same thing that I showed you with the clinical pictures can also happen under the microscope. So it's not uncommon for people to need, 3 to 5 biopsies before their diagnosis is made. And I can tell you that when I see patients, sometimes I look at the patient and I say, this patient has Mycosis Fungoides, but then I look at their biopsy, and if I had not seen the patient, I would not be able to say that for sure. And sometimes under the microscope, I also run into things where I'm like, this looks really worrisome for lymphoma. And then the patient gets sent to me, and I see the patient, and I'm like, this patient doesn't have lymphoma, or the spots are gone, So it's tricky both under the microscope as well as clinically. And then staging on lymphoma provides information. And what kind of information does it give us? It gives us survival statistics. But again, I tell statistics because they are just statistics. And they're getting better. But at this point, we're looking at data that's older. And the data can vary a lot depending on how you gather it and where it's from and what kind of things do you exclude. Questions? Yes.
Do you have more than one kind of cutaneous lymphoma?
Can you have more than one kind of cutaneous lymphoma? That's a good question. Yes, in theory, but it's rare. Yeah, there are some cutaneous lymphoma-like things called lymphomatoid papulosis, which you can see in conjunction with other lymphomas, in particular mycosis fungoides. So a lot of patients that have these two things together will have the classic scaly patches of mycosis fungoides, and then they'll have these like little bumps that come up in their patches. So you can have more than one cutaneous lymphoma, but it's rare. That one association that I just mentioned is the most common association. You can have other lymphomas that are not cutaneous. So people with lymphomas in general have a higher risk of a secondary non-skin lymphoma. That is definitely true.
Is staging it early put you in a predisposition, like a better chance of not getting those secondary lymphomas?
No, it doesn't.
No.
Early staging does not change your risk of a secondary lymphoma. It does, since you're diagnosed earlier, you're getting followed a little bit earlier better, but it doesn't change that.
So what's the risk? What's the percentage?
So the risk varies by lymphoma, and it, I would say 3 to 5%. I don't know if Dr. Carson has he does the other lymphomas, so that's why I'm looking at him.
That's a reasonable estimate, a couple percent. It's
Yeah.
still a fairly low absolute risk, but it is real compared to a population without the cutaneous lymphomas.
And that's why a lot of times when I'm talking to people when they first get diagnosed, and you're sort of deciding if you want a PET CT scan or a CT scan or not to look at your lymph nodes, if that's something to consider, because that way there's nothing there, and you don't run into trouble later. Other questions?
And obviously because you're a specialist, and we just had the experience with going through a couple of dermatologists and being misdiagnosed, is it just not the cross-training? I mean, obviously if you have something on your skin, you're going to go to a dermatologist. Is it just a lack of education, or is it because it's so rare?
It's because it's so rare. So I can tell you that I see people that trained under me and then go out into the community, and they think about it, and sometimes they send it in to the dermatopathologist just thinking about it, and the dermatopathologist can't make the diagnosis back. I know that I had looked at your husband's skin under the microscope, and I was concerned about it, but I could not make the diagnosis the first time. So then he came to Grand Rams, and then we took more biopsies, and then by seeing him and putting the biopsy together, we were able to make the diagnosis. But it's a difficult diagnosis to make, and it's so rare that 1,500 new cases in a year. If you think about how many a dermatologist is going to see in regular practice, there are not a lot of them.
Where are the most common places on your body to get it initially?
So I'll specifically start by talking about Mycosis Fungoides again, because it's the most common one. So that one comes up in places that we call double covered areas. So light treatment is a good treatment for Mycosis Fungoides, and Dr. Music is going to talk about it. And so if you think about it, a white t-shirt actually has a sun protection factor of about 4. So areas where you get, that's my phone, sorry, areas where you can get sun exposure, you usually don't tend to see it. So for women, a lot of times it's the breast area, and then in the general population, it tends to be kind of the stomach and buttocks, just because you have 2 layers of clothing there.
Another question. It was mentioned about nose polyps or something. Can you get it internally?
So you can have, there is a specific type of lymphoma that can affect the nose. So it's not Mycosis Fungoides, but there are some that can affect the nose. But you can have it anywhere on your skin.